get this going. Well, unfortunately, I wasn't able to salvage any the rest of my presentation, so I have a lot of my cardiogenic shock slides were already saved on this. I made a few changes to it, added a few slides, but they're not going to be there. We'll just wing it, and then we'll wing from treatment and hypovolemia on, and we'll try to get out of here pretty soon. So, for cardiogenic shock, if the pump says goodbye, my friend, you will die. That's really what this is all about. So we want to keep the pump from dying. All right. I'm going to give you. I'm going to brag just a little bit. My grandpa is 106 years old. He is the oldest living EAC alumnus who also taught. Although it wasn't EAC at the time, he taught for the Gila Academy. He taught chemistry and algebra. And he's 106 years old. He lives with my parents in Mesa. And he's awesome. He's such a cool man. He's done so many things in his life. He played semi-pro baseball for the Brooklyn Dodgers. You know, he's been in the wars. He was a bishop for the Mormon church, and one day when he was at church, heard an argument outside. He stepped outside, got shot in the chest, almost died. I mean, he's been through so many things. He's an amazing man. But I want to use his age to make a point about the marvelous thing we call our pump, our heart. Okay? He's 106 years old. That means that in one day, there's 1,440 minutes. That means in 1 year, there's 525,600 minutes in a year. Okay? So in 106 years, that's 55,713,600 minutes. But wait, right now you get the free kids, who knows? He has also survived through 26 leap years, which is an extra 37,400 minutes. So he's a total of 55,751,000 minutes in his lifetime. Assuming that his heart beats 70 beats per minute. Wait for it. That is a whopping 3.9 billion times that his heart has beat in his lifetime. My friends, the heart is an amazing pump. There is no man-made thing, and I'm sorry, my shameless plug, ain't no man and no happenstance can do that. That's God right there, my friends. That is an amazingly efficient pump. 3.9 billion times in his lifetime that heart is pumped, and he still does not, 106 years old, and he does not have one heart problem. Amen. That is an amazingly efficient pump. But, as efficient as that is, and I know that's kind of an enigma, but the human heart is the most efficient pump that we've ever known in mankind. We can't build anything that works better than that. But there's disease processes, and that being said, sometimes things go wrong. And when they do, cardiogenic shock occurs. And that's what we're going to talk briefly about, and then I'm going to kind of do a little comparison between the three types of shocks to kind of wrap it up. So what is cardiogenic shock?
Inadequate circulation due to the failure or inability of the ventricles, primarily left, to pump blood to the rest of the body.
What that means is that the pump fails. The heart, for whatever reason, has lost its ability to contract, to squeeze, to pump that blood to the rest of the body. If the rest of the body can't get blood, then we start to have problems with perfusion, and when we have problems with perfusion, we go into... Oh, I heard it. Man, you guys are brilliant. Good job. Okay. So, Stacy was supposed to teach the first part. She gives me, so. Based on what she taught, what part of the equation does cardiogenic shock initially fall into? When we talk about blood pressure is equal to the cardiac output, peripheral vascular resistance, with adequate venous return, where does cardiogenic shock fall into? Cardiac output. Very good. Okay? And that's initially. Why do we say initially? Why do we emphasize initially? Yeah, that's right. If cardiogenic shock is left untreated, pretty quick you're going to start to have peripheral vascular problems, and as a result of the peripheral vascular problems, you're not going to get very good venous return, and it becomes a vicious cycle. So, initially, cardiogenic shock is a problem with the pump, which affects cardiac output. Okay? Again, it will affect all of them if we don't do something about it. but that's initially what the problem is. Okay. Oh, this is one of my slides that I got some stuff cut out. Oh well. Preload. I want you to think of preload like blowing up a balloon. Okay? If you get a little water balloon, and you blow it up, you can't blow it up very big, right? But if you get a bigger balloon, you can blow it up really big. But what happens if you keep blowing it up and blowing it up? Yeah, it's going to stretch, and it's eventually probably going to pop. But the more that it stretches, and if you, over time, if you blow up a balloon a whole bunch, back and forth, back and forth, back and forth, it's going to lose some of its elasticity. It's going to get boggy. It's not going to work. Well, that's what preload is. Okay? It's just the amount of stretch in the ventricles, and primarily we look at preload in, depending on what we're dealing with, but since we're dealing with cardiogenic shock, we're going to look primarily at the left ventricle. So, we're looking at the preload in the left ventricle, and that is the amount of stretch in that left ventricle just at the end of diastole, just before the heart gives it that contraction to push the blood out. Okay? Afterload is the amount of pressure that the heart has to push against to get that blood out of the ventricle and into the aorta and into the body system. It's that resistance. And so I want you to think of afterload like blowing through a straw. If you have a really small straw and you blow through it or try to breathe through it, it's pretty difficult, right? It doesn't work as effectively. But if you have a good, decent-sized straw, you can breathe through it, it's okay. Have anybody ever tried to take like 4 or 5 straws and stick them in your mouth and try to breathe through it or take a fluid out of it or blow it? It doesn't work very good, does it? Same thing's going to happen. If you take a great big straw and you stick it in your drink, and you put your mouth around it and try to suck your fluid through there, how's it going to work? It's not going to work, okay? So what I want you to get out of this is, we talked about earlier that it has a lot to do with pressure, but it also has to do with flow. You have to be able to, even if you have adequate pressure, and believe me, in my hard head, never mind. In my hard head, I have a lot of hot air, but it's not enough to overcome. If you have a big straw, you just can't get very good flow, very good pressure. So that's what afterload is. It's just that amount of pressure that the heart has to pump into the vessels to get that blood out of the ventricles and into the rest of the system. I've added stroke volume and inotropes and dronotropes, and I guess that was an afterthought before I saved it, so it's not there. But really quickly, what is an inotrope? What does it affect? Contractility, very good. Okay, what is a dronotrope? The conduction part. Think of a drum like in the symphony of conductors. Okay, I don't know, I'm simple. But the dronotrope refers to the conduction system, and it affects primarily how electrical system is conducted through the SA node. Okay, and then chronotrope has to do with the rate. Okay, and that's important to know because a lot of the things that we do to treat will affect those things. So we need to be able to understand how we can affect those things. And when it comes to cardiogenic shock, we're primarily going to deal with inotrope and chronotrope. We don't do a lot with the rate because we'll talk about that. But just we have to have a little basic understanding of how the heart works. Okay, coronary arteries are unique to the body because they are the only vessels in the heart that receive oxygenation during diastole, when the heart's relaxed. Everything else is perfused during systolic blood pressure, when that heart is squeezing. But what happens is, just outside of the aorta, there's valves, and when those valves are closed during diastole, then it opens up those I'm drawing a blank. I'm totally drawing a blank. The valves that where the blood can passively flow down the coronary arteries and bathe the heart in blood. It's the only vessels in the body that receive nutrients during diastole, during the heart's relaxation phase. Okay? So that's very important when it comes to cardiogenic shock, because cardiogenic shock results in a low blood pressure, and if our blood pressure is low, we will not perfuse the cardiac muscle. Cardiac muscle takes, again, everybody's different. Some people don't read the textbook and know what they're supposed to follow, but it typically takes a MAP or a systolic or a diastolic blood pressure of 60 in order to perfuse coronary arteries. So when you start to get hypotensive and your maps start to go down, you stop perfusing your coronary arteries. When your coronary arteries stop getting fluid and the heart stops perfusing, then it affects its ability to contract, to pump, to do anything else, and the rest of the body suffers. So if the heart quits, you're done. So we got to be able to recognize that and then to reverse it. The reason that I wanted to show you the anatomy too is that when it comes to, well, let's look at the next slide. Okay, when it comes to cardiogenic shock, the number one cause is failure of the left ventricle. Okay, because it's the left ventricle is the big thick muscle that pumps blood to the rest of the body. If the rest of the body doesn't get it, then we have a problem. So you can have somebody that gets cardiogenic shock from a left or right ventricular failure, but it's going to be a lot more progressive, and hopefully that's caught by then. When somebody has cardiogenic shock from left ventricular failure, it's pretty detrimental, and it comes on fairly quickly depending on the cause. But the muscle just no longer can work, it can no longer pump it. It's like that balloon being blown up, and it just starts to get boggy. Anybody know what that law is, the contractility? Oh man, you guys are awesome. Okay, Starling's law. And what you want to be able to do is have enough contractility, enough beef to your heart muscle, that when it expands, when it contracts shut, there's enough power behind that, there's enough contractility that it'll force that blood out. But when you start to get, your heart muscle starts to die, it kind of loses that elasticity, and then it just is very soft and boggy, and it just doesn't pump efficiently. Okay? Another thing that can cause cardiogenic shock is rhythm disturbances. I don't know, I know this is a big group from first up to fourth block, and I don't want to get into the specific rhythms, but they're just rhythms that put you into cardiogenic shock because either you're beating so fast, you don't have enough filling pressure, and enough filling time, so the ventricles don't get enough blood in there. If it's beating so fast that you just can't move that blood into the ventricles, then it can't push it out, and your coronary arteries and the rest of your body don't get perfused. So if it's too fast, it can cause cardiogenic shock. We need to slow it down. The other thing that can happen is if it's too slow. If it's just too slow, that heart just gets really, think about sedating yourself. You just get kind of bombed. You're right after you drink a big Dr. Pepper or eat a big meal or something, and then you have to function, and you just kind of, oh. Well, that's what bradycardia does to your heart. It just makes it kind of slow, lethargic, doesn't react very well. So we need to fix that. Pericardial tamponade is another. When it comes to traumatic cardiogenic shock, excuse me. Stop. When it comes to cardiogenic shock from trauma, this is the number one cause, and that's pericardial tamponade. And what is pericardial tamponade? Fluid in the pericardium. Very good. There's a sac around your heart that is not supposed to have fluid in it. When it does, what happens is that fluid starts to expand in that sac, and then it just compresses the ventricles, and they lose their ability to contract because there's so much pressure. It does not take very much fluid, especially around the left ventricle, to cause that problem. Everybody likes stories. I'm just going to tell you a quick story because it was so cool. We flew to a motor vehicle accident right outside of Fort Grant one time, just down the road from Fort Grant. We got there, patient was in a motor vehicle accident, had been trapped in the car, got him extricated, pulled him out, and he was in cardiac arrest. There's a trauma code. Put in 2 chest tubes and did everything we could think to do, and it just wasn't working. Well, my partner, my nurse partner, who's pretty Johnny on the spot, she was awesome. She says, I don't know, he's starting to get his neck veins are filling up. I think he may have a tamponade. Let's try it. Now, this guy had been asystolic for about 8 minutes. We'd been working him, doing our thing. And she did a pericardiocentesis, stuck a needle through, stick it underneath the ribs right here, and you go into the heart. She dropped 8 cc's of fluid. That is not very much. 8 cc's. And his heart started beating, and he survived. So, pericardial tamponade, 8 cc's. That's all it took for that guy's heart to compress and to stop him from being able to function. Now, granted, he had other things going on, which made it worse on him, but all it was 8 cc's. He dropped 8 cc's of fluid, and his heart started beating again. So that's pretty cool. And he was in big-time cardiogenic shock. But Beck's triad to recognize that, what we're talking about with that is that you have your jugular veins just get really distended and engorged. I mean, you ever seen a weightlifter and they go, you know, and they stick out? They'll look like way bigger than that. They're so engorged because you're getting back pressure. There's so much pressure that the heart, it can't stop pumping that out, so it just starts backing up in the system. And those neck veins get really distended.
I have a question. Is that the only place they could have drawn that fluid out of?
Yes, ma'am.
Drawn into that jugular, the distended jugular?
No, we don't go through the veins. We actually go underneath the rib. And what you do is you point it kind of, it's called the ipsilateral nipple. That's what you're doing. You're starting right here, you're going at a 30-degree angle, and you just go until and you can use the monitor to watch, because as soon as the needle touches the ventricle, the monitor will start, because you're irritating the ventricle. And as soon as you do that, then you just start drawing back on that syringe, and as soon as you kind of move it around to find where you need to go, and you'll all of a sudden you just go, oh, and start drawing fluid. You should never be able to do that. If you go too deep, you'll get into the ventricle, but you'll know, because the minute you touch that ventricle, it gets irritated. And as soon as you do that, then you just start drawing blood back, and until you can't draw any blood back. And once you remove all that blood, then the heart can actually expand again. It's like a tension pneumo. It's like taking the air or the fluid out of that space so the lung can fully inflate again and start functioning. And that's exactly what pericardiocentesis or pericardial tamponade is doing. So that centesis will pull that blood out and allow it to function. So you recognize that by JVD, by very muffled heart tones. If you listen to heart tones at all, usually it's pretty distinct. That love dove. Well, all of a sudden it just sounds really muffled, like it's yeah. Say it just becomes. It's a very distinct. Wow, that is not audible like it should be. And then the other thing Gary had talked about is that narrowing pulse pressure. Let's say your initial blood pressure, kind of hard to do if they're asystolic, but if their initial blood pressure was 120 over 80, well, their pulse pressure is 40, right? Because the difference between the 120 and the 80 is 40. Well, then the next one is 110 over 90. And then the next one is 105 over 100. And you see that pulse pressure narrowing, that is very indicative of cardiac tamponade. So you want to be able to recognize that and do something about that. Okay. The other thing that causes cardiogenic shock is if you have ruptures of the muscle or tendon that affect the valves, so they can't close and open it very well anymore, and so you start to get fluid back up. And when those valves don't close, you lose elasticity, you lose the ability to contract because it just pushes blood out, so you're going to stop perfusing. Instead of pushing it forward, it just pushes it wherever. And then septal tears between the right and left ventricles, and that can happen from trauma, it can happen from somebody that's had cardiomyopathy or somebody that's had hypertension for a long time, and so there's just lots of pressure and it just starts to break down. But those are rare. The biggest causes, I want you to remember this, of cardiogenic shock is a heart attack, particularly the ones that affect the left side of the ventricle. So when you're looking at the 12 lead, you'll see, anterior and lateral changes, and those are the ones that are going to have problems with cardiogenic shock. So you want to be ready for that. You don't want to get behind the eight ball. Signs and symptoms. These are pretty self-explanatory. You have heart attack, the symptoms are the same. You have trauma, the symptoms are a lot the same. You're going to have chest pain and pressure. They're going to be short of breath. They're going to be dizzy. They're going to be breathing really fast because they're trying to compensate to blow off some of that buildup of lactic acid, CO2, all that stuff that they're getting because they can't perfuse. Tachycardia, and we're going to talk a little bit about why that happens. Diaphoresis, sweating like crazy. And especially when they're truly in cardiogenic shock, man, they'll and that won't last long because they'll pretty quick, they'll not be able to sweat. But the altered level of consciousness, all these things. The only thing that I want to really point out, we don't monitor in the short-term urinary output, but that's a very good way to show cardiogenic shock. Because if it continues for very long, then it starts to shut down the kidneys. That's the first organ that the kidneys and the brain get affected. And so that's one way you start to find out if they have cardiogenic shock or some other things is what's their urinary output. coma, and then positive orthostatic vitals. What is that? Okay. Yeah, you're taking their vital signs from the laying position, and then you wait a couple, you stand them up and wait a couple minutes, and you take it from the standing position, or you can have them sit. And if you have changes, what you're looking for primarily is first the heart rate. That's the fastest one to see. If your heart rate increases by 15 to 20% from lying to sitting, okay, and then their blood pressure drops 15 to 20% from lying to sitting or standing, and that's pretty indicative of them having orthostatic blood pressures. Typically that means hypovolemia, but why would that be an indicator in cardiogenic shock? Yeah, if you're not getting perfusion, if it's not pumping, okay, so that's not the only thing. Typically when you see that, you look more at hypovolemia, but if you start looking at other signs and symptoms, you have to, and you've tried fluid replacement, you've tried whatever, it's not working. Okay, what's the other problem now? And you have to maybe consider that it's cardiogenic shock. Okay, so this is where my slides go. Okay. I just tried to scribble some notes real quick so I could. I'm left-handed, and I'm going to stand in front of this, but I'll move out of the way. Okay. I'm going to combine, just for the ease, since I don't have my slides, a little bit. And you know what? Maybe I'll leave it this. Okay, we're going to call this cardiogenic. We're going to call this hypovolemic. We're going to call this distributive receptive. Okay, and then we're going to look at a few categories. And these are signs and symptoms. We're going to talk about comparing these things and then why we do some of the treatments we do. Hopefully it makes sense. Okay, so when it comes to cardiogenic shock, well, anything, we're looking at cardiac output, heart rate, systemic vascular resistance, blood pressure, and skin temperature. Okay? With cardiogenic shock, what's the cardiac output going to be, up or down? Down. Okay. What's the heart rate going to be? Why? Okay, good. Now, the heart and the body, you know, it's amazing because it has lots of compensatory methods. It has lots of ways to fix its own problem. But the problem is that some of their compensatory methods also can be detrimental. If the heart rate stays high for too long, what happens? Yeah, it increases the oxygen demand, and so we got it. That's an early sign. When you see that heart rate go up, you know right away, okay, something's going on, and you need to start identifying what it is, because if that stays going on too long and we don't correct it, it's going to make the problem worse. The higher the heart rate is and the longer that continues, the greater the oxygen demand on the heart muscle is. And it's just a vicious cycle. It's going to make itself worse. You've got to be able to identify that. So yeah, the heart rate's going to be up in cardiogenic shock. What about systemic vascular resistance? Okay, when we say up or down, I'm talking about normally the vessel's here, and when the vessels constrict, then the resistance is higher, correct? Because now it's having to push harder. That pressure and that flow is having to work harder to get through that system. When it expands or dilates, now it just doesn't matter how hard it pumps, there's just not getting enough flow. Okay? So in cardiogenic shock, is the systemic vascular resistance going to be higher? Is it going to be up, or is it going to be lower? Higher. Very good. Okay, that's because the vessels constrict, and that's a compensatory method for the body. That's the body saying, hey, we got to make this pressure work better, so we're going to constrict those vessels so that it increases the pressure, and we can try to perfuse better. But again, if that goes on too long, and we don't correct it, we start to lose perfusion. So all of these things are great compensatory methods, but if we don't fix them, they're going to they're going to fix themselves by dying. Okay? So we gotta be able to recognize that. What's the blood pressure going to be like? It's going to be down. That's right. Because it's a pump problem, right? They're no longer perfusing. You may initially see from anxiety, from whatever, a little bit of a raise in their blood pressure, but in true cardiogenic shock, in fact, one of the ways they diagnose whether it's cardiogenic shock is simply by hypotension. Because if you get hypotensive, remember we have to have a diastolic or a mean arterial pressure somewhere in the range of 60. If we get so low, if their blood pressure is 90 over 40 and then 80 over 30, that bottom number, there's just not enough pressure to perfuse those coronary arteries. So in true cardiogenic shock, you're going to see the blood pressure go. What's the skin temperature going to be like? Is it going to be warm or cool? They're going to be clammy. So what does that mean? What's going on? That's right. Okay, good. The skin is going to constrict because it's a body's defense mechanism to shunt blood. The skin is an organ that's considered non-vital. You don't have to have, it is kind of vital because it protects you from diseases, but when it comes to an immediate emergent need to survive, the body will sacrifice the skin by shunting blood away, constricting all those vessels in order to push that blood to your heart, to your lungs, to your brain, and then secondarily to your kidneys. It'll shunt it away from all the other stuff because it doesn't need that to survive, but it needs those to survive long term. Okay? All right. So that's the big thing with cardiogenic. Go ahead.
If patients have already been for so long that they get JVD, would that raise on my blood pressure?
No. If JVD is not caused by high pressure, what it's caused by is that the heart has become so boggy that it can't keep up with the venous return, so that venous return starts to back up. So it just can't pump it out fast enough, and so instead of that blood being just effectively pushed through the system, the heart is just failing. And the venous system, it doesn't take hardly any pressure. Remember from your anatomy and physiology, pressure really has primarily to do with making the arteries move blood forward, right? And the venous return, you do have to have pressure, but it'll do a lot of it passively. And so if the pump starts to fail and it's not pumping blood efficiently, it's still going to move that. You're still going to get decent venous return, at least initially. But if the heart can't pump it out, then it just starts to back up. It's like congestive heart failure. It's like anything else. You're just going to get that fluid that's going to back up. And as it backs up, then it engorges those jugular veins.
So it's not on the ring, still going to be a low pressure.
That's correct. That's correct. Okay.
So your body is going to, your peripheral vessels are going to make it constrict.
That's correct.
So then wouldn't your SPR go up?
No. Oh yes, did I write? I thought that's what we said. Yeah. Thank you for that. That's what we were talking about. It goes up. And I just wrote it back. It goes up because the vessels constrict, so now the pressure is higher. I'm sorry. And that's what we all agreed on. But I just wrote it back. Yeah. I just wrote it back. Hey, 5 out of 4 people are dyslexic. Now let's talk about hypovolemia. And in reality, in a critical care setting, see, I'm not a nurse. So I don't come from a real critical care setting. I come from, even though we do it on the helicopter, but there's a couple other things that in a critical care setting, in an ICU that you would look at to determine cardiogenic shock versus hypovolemia. And that's pulmonary artery wedge pressures, and that's also jugular venous pressure. That's 2 other things that you would monitor through central lines. I don't really want to get a whole lot into that, but in an ICU setting, that is the #1 thing you look at to tell the difference between cardiogenic and hypovolemic shock. They're opposite of each other. Okay? In cardiogenic shock, the JVP and the arterial wedge pressure is going to be up, where in hypovolemia they're going to be down. So that's primarily how you diagnose the difference. Okay? But I don't want to get into that because that's not something that I'm comfortable enough to explain because it's a critical care thing and I'm retarded. So we're going to move on. Hypovolemia, though, what's the CO cardiac output going to be? Low. Because you don't have enough volume. We're not perfusing enough volume. What's the heart going to be? Same thing, right? Okay. What's the SVR? reason I'm showing you this is where it becomes absolutely vital that you become a good clinician. You become good at taking a history, you become good at looking at signs and symptoms, and you become good at being a critical thinker. Because obviously there's two different reasons this is occurring, but the signs and symptoms are the same. So the things that I showed you for cardiogenic shock, those signs and symptoms are going to be predominantly the same thing when it comes to hypovolemia. You're going to have chest pressure, they're not perfusing. And you won't have that quite as much with hypovolemia, but that's another way you can indicate, are they having chest pain? But in long-term hypovolemia, heart's not getting perfused anymore, they're going to start to have chest pain. But the heart rate's going to go up, they're going to be confused and disoriented, if indeed, then why is that? Because in hypovolemic shock, there's not enough volume, so you don't have enough red blood cells circulating that blood, and so it's going to affect everything just like cardiogenic shock. You're going to be confused, you're going to be lethargic, you're going to get, all of those signs and symptoms are going to be the same. So the key is that you have to be able to recognize the differences. And so I want to talk really briefly about that, and we're going to talk about, just as a gee whiz though, let's look at the spiritual shock so we can understand some business. What's the cardiac output? Why is it up? Good. Why is it up? Okay, speak up.
Your vasodilated, so you have more, your pipes are open, so more blood can come out. Your SVR is low, so when you pump, you get more out.
That's right. So really what it becomes now, we talked earlier about pressure, this becomes a flow problem. This is where you have your flow problems. The vessels are so big that you just can't get the flow to go through them. The pressure's okay, but they're just so big that you can't circulate water through it. If you have a great big 2-inch water main at 90 psi, which is what your normal, like a house water system is, it's not going to flow very good. It's the same amount of pressure, it just means it's that bigger vessel, you can't move that fluid. So that's exactly why the cardiac output initially is going to be higher. That's one way to tell that. What about the heart rate? It's going to be up too, all the same. Okay, we have a big difference here. I think I just gave it away. What's the percent vascular resistance? Way down, really low. It's a distributive problem. It can no longer distribute because that resistance, it's so loggy, everything's so big, you just can't push the fluid. Okay. Blood pressure. Yeah, okay. And this is really, these things are very similar, but there's some key differences to deciding. We're going to get to that right here. What's the skin? Okay, we already talked about that earlier. The skin is warm, the skin is pink, in fact it's usually hot. Why? Fever. Vasodilation fever, okay? And that's one of the biggest ways you tell the difference. Right away, you walk up and you can tell somebody's in shock, right? A lot of the symptoms are the same. If you walk up and touch somebody and they're cool and clammy, chances are it has nothing to do with the distributive problem. It's going to be here or here. But if you walk up and touch somebody and they're just red hot, they're warm, and they're feverish, you can automatically go, you must have a distributive shock problem. Okay? So that's the fastest way you can tell the difference between those three. All right, so really quickly, treatments are easy, but you have, with the hypovolemia, the number one thing is fluid. Okay? You can start out by you want to give crystalloids, you want to give something like normal saline, and you want to give it fast. But is fluid alone going to fix that problem? Why are they low volume? It depends. Are they low volume because they're bleeding out? Or are they low volume simply because they're so severely dehydrated? Okay? So it depends. You have to be able to look at the history, find out the history. If it's a traumatic thing, it's probably hypovolemic. If it's a GI bleed, it's hypovolemic from a blood problem. If it's because they've been outside working and they have a heat stroke, it's a volume problem because they've sweated out. So lots and lots and lots of fluid. But if they're truly hypovolemic because they're bleeding, and you give lots and lots of fluid and that's it, what are you going to do? Yeah, we call it making Kool-Aid. You're going to just dilute it down so much, there's no longer any blood vessels in there, or any red blood cells in there to carry the oxygen, and so even though you're giving enough fluid to the pump to prime it and let it work, they're not going to perfuse because they no longer have any red blood cells. So when it comes to hypovolemic shock, you have to figure out, is it because they're sweating it out like crazy or because they're bleeding out? And it's easy to tell by taking the history. They're throwing up blood, they're passing blood in their stool, they've got shot in the chest, that's pretty obvious, you know, they have to look and have a broken femur. And when it comes to fractures, femur and the pelvis are the big ones we look for volume. Why? They have lots of arteries. You can bleed out. Average person has 4 to 6 liters of fluid in their body. You can bleed out in your thigh. You can bleed out 4 liters of fluid very quickly. If you bleed out 4 liters of fluid, you are not going to survive for very long. You don't fix that problem. Okay? The other thing that happens, well, I don't know. Same thing with the pelvis. Okay? There's so many vessels in there that are going to bleed out. So you need to replace that with fluid and with blood. But the number one thing is it needs to be corrected, right? And so they need a surgeon. It's a surgical emergency. Same thing with the GI bleed. Same thing with any kind of trauma. It is typically a surgical emergency. So they need, we talk about IV fluid and blood fluid, but there's another fluid. It's called jet fuel fluid. And if you're in a rural area and they don't have a surgeon available, they need a very quick bolus of jet fuel to get them to Tucson or get them to Phoenix or wherever it is you work, because it is a surgical emergency. If that bleeding problem does not get corrected, they're going to die. So we have to be very quick about identifying what the problem is so that we can get them the proper care. But as far as what we can do, it's going to be fluid and blood. Okay? Any questions on that? Hypovolemia is pretty simple.
Is there really enough fluid in hypovolemia to create diseases?
Um,
Is there enough fluid left in the body to create vascular disease?
Initially, yes. But if it keeps going, there will not be. That's why it's important to recognize right away, to be a good clinician and take a good history. Because initially your body reaction to, oh crap, I'm sensing that there's a problem going on with giving fluid, so it's going to constrict to increase the pressure to push that fluid further in. But as you start to lose fluid and pressure, and you start to get more and more shocky, then a late, very bad sign is that all of a sudden you lose that ability to have resistance. You've now lost your norepi and all those things that contribute to keeping those constricted. They fail because they're not being perfused, so your body can no longer dump those, and then it starts to relax. That is a very late sign. That's bad. If you're seeing that, that's a very high mortality rate. So that's why we've got to catch it early. We've got to recognize what's going on early. Okay? As far as cardiogenic shock, the number one drug that we give for cardiogenic shock is dobutamine. And why do we give, we can also give dopamine secondary to dobutamine, but let's talk really quick. I want to see what you guys know about it. Why do we use dobutamine over dopamine? Dopamine does. That's dobutamine. It is primarily, they're called, both of them are called alpha-adrenergic drugs. That means they work on alpha receptors, beta receptors. But there's two kinds of beta, well, there's really three. There's two that we care about. B1 and B2 beta receptors. B1, the way I remember it, is there's only one heart, so B1 affects the heart. B2, there's 2 lungs, so B2 affects the lungs, primarily. Well, dopamine primarily is almost purely a beta drug. So it's only primarily going to affect the heart. And it's only primarily going to affect contractility. It's going to affect the inotrope. Okay? It's an inotropic drug. So it's not going to it really doesn't say, when you say we're giving dopamine or dobutamine to increase their blood pressure, you're really not doing it. Dopamine's not increasing their pressure. What it's doing is it's making the heart contract better, which as a result will then give you a higher blood pressure. Dopamine is different because it does have some inotropic, but it is very, very potent vasodilator. So what kind would that be? Yeah, vasoconstrictor. Sorry, I said that backwards. So what kind of is that going to be? Inotrope, chronotrope? Okay, it is inotrope, but it also affects the heart rate. It's chronotropic, And it is a very, very, very potent vasoconstrictor. Well, do you want to do that in somebody that's in cardiogenic shock already? You don't want to increase the workload. And so when you constrict even more, then the heart it increases the myocardial oxygen demand. So you don't want to give that as a first-line drug for cardiogenic shock because it really increases the oxygen demand of the heart. Dopamine is the best thing to give. I mean, dobutamine, I'm sorry, I'm saying that. Dobutamine is the best thing to give. How do you mix dobutamine? Okay, you mix it, you can mix it in D5 or in saline, but we mix it, we call it a 1-to-1 concentration. 250 milligrams to 250 cc's. That gives you 1,000 units per milliliter. Okay, and then the dosing range is 2 to 20 micrograms per kilo per minute, so it's weight-based. And you know what? We have a great little pump that they use about for us because I'm good. Okay? And you can titrate it 2 micrograms. You know, the literature says every 15 minutes, but in reality, we do it every 5 minutes if somebody's really critical. Okay? Now, you've got to max them out on the dobutamine, you can add dopamine, but one of the things you may want to do is consider a little bit of fluid. And with cardiogenic shock, you're talking a little bit. 50 cc's, that's a good bolus right there for cardiogenic shock. Just enough to make sure that their volume is enough because dopamine is really going to help. It's not going to work if you don't have good volume. Okay. So the other thing, we can use other things to help. We can use vasopressin, norepinephrine, and for cardiogenic shock, but you have to be really careful with that because again, it's going to increase your oxygen demand. So you want to be really careful. The take-home point when it comes to cardiogenic shock is to recognize what's causing it, to correct that problem. Because you can give drugs, you can give anything, but if you don't correct the underlying problem, you're not going to do the patient any good. The take-home point with hypovolemic shock is the same thing. If you don't correct the problem, you're just buying time, but they're going to eventually die. So you have to recognize what is causing that. And that comes by being a good clinician, asking good questions. Okay? So hypovolemic shock, what are the 2 fluids that we give? Saline and blood. Okay? Very good. With cardiogenic shock, what was that? Dobutamine first, okay, and dopamine second. The other thing that we all get excited about our advanced skills and our advanced medicine, the medications we can give. But when it comes to cardiogenic, hypovolemic, or distributive shock, the best drug that we have is oxygen. Really what it is it's a perfusion problem. So the more we can give them oxygen, the better the chance they're going to have to saturate what hemoglobin are left, or what hemoglobin are getting through to the capillary bed. So you want them on oxygen and typically high flow. If they're truly in these kinds of shocks, you want high flow oxygen. That is the best drug that we have to give them because that's going to increase their perfusion. So don't forget, don't get all excited about your basic stuff, about your advanced stuff, that you forget your basic stuff. Oxygen, oxygen, oxygen. That's the best drug we have. Okay? That pretty much sums up treating cardiogenic and hypovolemic shock. I hope I didn't confuse you. I didn't have my slides, my PowerPoint to follow along, keep me on track. Does anybody have any questions about that? Okay, good luck, you guys.
I would like to thank Gary and Randy, and we have some presents for them. And thank you, Bart. Also, we would like to give a special thank you for Carolyn McCormick, our nursing director, for her support and investment in our futures. And last but not least, clean up your area and don't forget to turn your filled-in evaluations at the door. There are students who will be collecting them. Thank you very much, everyone.